The paradox. For decades, cannabis has been framed as safe, natural, even therapeutic. It treats nausea. It stimulates appetite. It calms the nervous system. But today, millions of people are discovering a paradox. For some chronic users, cannabis stops calming the system and starts breaking it. This condition is called Cannabinoid Hyperemesis Syndrome, or CHS. A disorder where the same substance used to prevent nausea begins to cause uncontrollable vomiting, not from overdose, not from contamination, but from long-term biological adaptation. And to understand CHS, we have to stop thinking about cannabis as a drug and start thinking about it as a systemic signal that rewires the body over time. Such a thing as too high. When? What CHS actually is. CHS is defined by recurrent cycles of severe nausea, intractable vomiting, abdominal pain, dehydration, repeated emergency room visits. What makes it clinically confusing is that standard anti-nausea drugs often don't work. Ondansetron fails, metoclopramide fails. Patients keep vomiting anyway. One behaviour shows up again and again: compulsive hot bathing. Patients will take scalding hot showers for hours, sometimes the only thing that provides temporary relief. This isn't psychological, it's neurobiological, and it's one of the strongest diagnostic clues clinicians have today. 324453, unravelling the enigma of the three phases. CHS develops in three phases. 1. Prodromal phase, morning nausea, mild abdominal discomfort, continued or increased cannabis use, symptoms often dismissed. 2. Hyperemetic phase, explosive, cyclic vomiting, inability to eat, severe electrolyte imbalance, hot showers as symptom control, frequent ER visits. 3. Recovery phase, only occurs after complete cannabis cessation. Symptoms resolve over days to weeks. Many patients relapse and restart the cycle. Crucially, reduction isn't enough. Switching strains doesn't work. CBD doesn't reliably fix it. Only abstinence resets the system. The endocannabinoid system breaks. The endocannabinoid system, ECS, regulates gut motility, nausea control, temperature regulation, immune signaling, stress responses. Cannabis floods this system with exogenous cannabinoids, especially THC. At low or intermittent exposure, THC is antiemetic, but chronic high-frequency exposure flips the signal. Here's what happens. CB1 receptors desensitize. Gut motility becomes dysregulated. Nausea circuits in the brainstem become hyperreactive. TRVP1 heat receptors become over-involved. This explains why hot showers help. Heat activates TRPV1 receptors, temporarily overriding the broken nausea signal. You're not treating the disease, you're hacking around a malfunctioning neural circuit. The immune system enters the story. Here's where new science changes everything. Recent transcriptomic studies show that CHS is not just neurological. Blood RNA sequencing reveals upregulated B-cell immunoglobulin genes, altered T-cell and monocyte signaling, increased HLA, class 2 expression, restricted HLA class 2. Allele usage, markers consistent with allergic hypersensitivity. In plain terms, CHS may be an acquired immune hypersensitivity to cannabis localized in the gut, not inherited, not immediate, acquired over time. This reframes CHS as something closer to a food allergy, a drug-induced gut hypersensitivity, an immune-mediated barrier failure. The gut lining shows signs of impaired adhesion and increased permeability, allowing immune activation to spiral. Cannabis becomes the trigger, not the toxin. Why diagnosis takes years? Average time to diagnosis, 3 to 6 years. Why? Cannabis is assumed to be anti-nausea. Patients increase use when symptoms start. Labs and imaging are often normal. Providers rarely ask about cannabis patterns. Even today, only about 11% of people with CHS symptoms report receiving a formal diagnosis. That means millions are suffering without a name for what's happening. How big is this really? National data now shows approximately 15% of US adults report daily cannabis use, approximately 17.8% of daily users report CHS-like symptoms. That's over 7 million Americans. CHS is now the most common cannabis-related cause of ER visits. Legalization didn't create CHS, potency and frequency did. Treatment and the future. Acute relief, haloperidol, capsaicin, IV fluids. Long-term cure, cannabis cessation. But emerging research points to future directions. Immune biomarkers for early detection, HLA-based risk stratification, gut-targeted therapies, TRPV1 modulating treatments-induced tolerance strategies. CHS isn't a moral failure, it isn't weakness, it's biology adapting past its limit. The real message. Cannabis isn't harmless and it isn't evil, it's powerful. And when a powerful signal is pushed too far, for too long, systems break. CHS is the body saying, this pathway is saturated. Understanding that isn't anti-cannabis, it's pro-biology, and awareness is the first treatment.